Good evening, everyone. I want to welcome everyone to the Advanced Practice Provider webinar series in joint with SMSNA and our sponsor, Endo Men's Health. This evening, we have a fantastic program on testosterone to treat prostate cancer, a complete paradigm shift. We're extremely fortunate to have two renowned speakers in testosterone. We have Dr. Abraham Morgentaler, who's the immediate past president of the Anderson Society and associate professor of surgery at the Beth Israel Deaconess Medical Center at Harvard Medical School. We also have Dr. John Mulhall, who's the director and sexual reproductive medicine and urology service at Memorial Sloan Kettering Cancer Center, and also the chair of the AUA testosterone guidelines. The format for this evening will begin with Dr. Mulhall giving a 20-minute lecture on the testosterone to treat localized prostate cancer and potential protective effects, followed by Dr. Morgentaler discussing testosterone to treat metastatic prostate cancer and potential therapeutic effects. And finally, we'll end with some case presentations and some discussion. With that, I'll actually ask Dr. Mulhall to go ahead and start sharing, and I'll stop sharing my screen. Thank you.
Can you see my slides, Abe?
I can see them.
Okay. Well,
Yes.
it's my pleasure to be here. Thank you all for being here tonight. And I'm honored to speak with these two chaps who, of course, are renowned in the testosterone space. So I think we're going to talk about a lot of interesting concepts tonight. I have no T-therapy disclosures. The other thing I think that's important to say is that any discussions of testosterone therapy in the prostate cancer population are off-label. I'll be interested in hearing from Abe what he thinks it might take to get the FDA to change that label restriction, as I think we're at a point in time where some consideration should be given to that. Terminology, I'd really like you in your clinical practice to use the terms testosterone deficiency and T-therapy, as opposed to the term hypogonadism, which I think is an outdated term. Testosterone deficiency is not the same as low testosterone. Testosterone deficiency is low testosterone in combination with symptoms and or signs. The symptomatology, whatever questionnaire or list you use, is incredibly nonspecific. It is shared with chronic stress, chronic fatigue, depression, and maybe even sleep apnea. When you see a patient and they have a low testosterone level, you're not sure what the patient's physiologic set point is, because typically it's a 55-year-old man coming in to see you and you don't know what his T level was when he was 20 for the vast majority of patients. And then, of course, the T product label says that we should not give testosterone therapy to men with prostate or breast cancer. The risks and benefits of low testosterone. The risks are cardiovascular events, glycemic control issues, bone density loss, impaired nerve recovery. This is particularly important at a cancer center and radical pelvic surgery. All of our prostatectomy patients get T levels checked, as low T has been shown, at least in animal and in vitro models, to be a neurotrophic hormone. Impaired PSA production, I'll share some data on that. And then I think the evidence is pretty clear that low T is associated with a higher risk of having higher stage, higher grade prostate cancer. There are no benefits to low testosterone. What about T therapy? Risks and benefits. Risks, well, there's an absence of long-term safety data in the prostate cancer population. Polycythemia rates are, as you see listed here, higher in patients who are on intramuscular testosterone therapy. Whether the polycythemia or the gynecomastia are related to peak levels or C average levels is not clear at all. But there's no clear evidence that major adverse cardiovascular events is associated with T therapy. And likewise, venothromboembolic events, although there was a paper that was published within the last couple of months that suggests that that might be a concern, although I'm not completely familiar with the methodology in the paper. The benefits for T therapy, potentially reduced MACE risk. There is a smattering of papers that suggest that's the case. And it's certainly my personal belief, well, that will be an eminence-based medicine concept. We really need Mo's TRAVERSE study to come out to look at that carefully. And I'm sure Mo will talk about that. The potential for optimization of glycemic control, bone mineral density preservation, and perhaps improved nerve recovery after radical pelvic surgery. This is just a smattering of the literature that suggests that testosterone is a neurotrophic hormone. And as I said earlier on, all of our prostatectomy and cystectomy patients and radical rectal surgery patients get testosterone levels checked. Without belaboring the point, I'm sure you're very familiar with this paper, the Huggins and Hodges paper, which established the kind of concept that testosterone therapy may be associated with prostate cancer progression. And just to point out to you that it really involved just 3 patients who had metastatic disease. So they had metastatic disease at the start. I know Abe is going to talk about testosterone therapy and metastatic disease, but in this era, in the 40s, this was absolutely unheard of. The results were only reported for 2 patients, one of whom was already castrated, so he had no testosterone. And when men start off with 0 testosterone, you give them testosterone, we know that there's a proliferation of prostate cancer cells. So essentially, you had one relevant non-castrate patient, and there was no PSA in that era. It was just prostatic acid phosphatase, and that rose with testosterone therapy, as we would have expected. So metastatic prostate cancer, historically, we would think of as a different biological entity to men with organ-confined cancer or post-prostatectomy patients. This is a statement from the AUA guidelines that you should measure at PSA in men 40 years of age or older prior to T therapy. This was a point of great discussion during the panel. And the reason it was decided to put this in was to really protect the prescribing physician, that we didn't want physicians being accused of giving testosterone therapy to men who had prostate cancer. The AUA guidelines focus on patient and clinician protection. We had this discussion with oncologists, and they helped us decide how to phrase this statement. So again, the AUA is all in favor of shared decision-making, and a normal PSA prior to testosterone therapy should be evaluated further. This is an old slide, but raises the question, how come prostate cancer rates are highest in men when their testosterone levels are declining the most? And I think that's the first signal that perhaps prostate cancer development is not necessarily related to a man's testosterone level. This is the Lenny Marks paper. This is a small study. I wanted to concentrate on the left-hand panels, which are serum testosterone. Top panel is serum and the bottom panel is prostate tissue. These are men who are randomized, small number, randomized to testosterone therapy versus placebo. There's a baseline testosterone level on the upper panel and a 6-month testosterone level in response to testosterone therapy and placebo. Obviously, the testosterone level rises in the testosterone therapy group. But more interestingly is the bottom panel, which is prostate tissue levels. And you can see, even though the testosterone level goes up in the replacement group, there is no change in testosterone level within the prostate. This is the AUA guideline statement for the prostate cancer patient with testosterone deficiency. There remains at this point in time inadequate evidence to quantify the risk-benefit ratio of testosterone therapy. There's an updated literature review going on at the moment, so hopefully at the end of this calendar year, we'll have an update to the AUA guidelines, and let's see if this statement can be changed. This is a very interesting slide, and I want you to pay particular attention to the black bar. This is a study performed by Dr. Morgenthaler way back in 1996, published in JAMA. And this is looking at men who came in, I believe, for consideration for testosterone therapy. They had a PSA level less than 4, and they were all biopsied. And what it showed was, if you take those men who are candidates for testosterone therapy with a PSA level less than or equal to 4 nanograms per ml, that 14% of them actually had prostate cancer within their prostate. So whether we know it or not, we're giving testosterone therapy to men who harbored cancer inside their prostate, most probably low grade, low volume, low to intermediate kind of 6 Gleason 3+4 kind of cancers that will probably do nothing in the future. The literature as it stands at the moment is a series of relatively small case series. There's actually 4 of them now, but the biggest one is Alec Pasturzak's and Mo Kara's 103 patients of mixed pathology, mean follow-up of 27.5 months. And there were 4 patients out of the 103 who had biochemical recurrence, all of whom had higher grade prostate cancer. In those patients who had low to intermediate grade prostate cancer that was organ confined, there was no biochemical recurrence, at least at the 27.5 month mean follow-up. Okay, so this data does not convince us that it is safe, but it certainly gives us a signal that this is definitely worth exploring further. This is data that we published many years ago. These are men who had neoadjuvant androgen deprivation therapy, high-risk cancer, neoadjuvant ADT. You can see on the top panel, bilateral nerve sparing, unilateral nerve sparing, and non-nerve sparing. In the light gray are those men who had androgen deprivation therapy, and in the black, those men who received no ADT. Again, fairly small numbers. And you'll see that men who had bilateral nerve sparing, who had androgen deprivation therapy, had very, very low EF domain scores. The percentage of men who had EF domain scores 24 or over, which we would consider to be functional, was only 1 in 4. So you take men by giving them neoadjuvant androgen deprivation therapy, even though they have bilateral nerve sparing, and you dramatically reduce the chances of them being functional after radical prostatectomy. Now, there are good reasons in certain populations why neoadjuvant ADT is used, cancer control, of course, but the patients need to be informed that this will almost certainly translate into a change in their erectile function that is permanent. If you look at the bottom, you'll see the odds ratios for men developing severe ED, that's less than or equal to 10 on the erectile function domain score of the IIEF, and you'll see that those men are 13 times more likely to have severe ED if they were exposed to androgen deprivation therapy. And this ADT exposure is very short. It's only about, in this series, about 4 months. Congratulations to Abe for introducing and promulgating this and persisting in the war of attrition that it has been to get testosterone therapy accepted in the prostate cancer population. But this is a saturation model. And this is based on LINCAP cells. And when you have LINCAP cells, which are androgen sensitive prostate cancer cells, when they're in a petri dish and they have no testosterone, there's no proliferation. When you give them some testosterone, there's a linear proliferation rate up to a certain point, and then there's a saturation effect. And if you continue giving them more and more testosterone, historically we said, listen, they just saturate and there's no proliferation. More recently, there's been some interest in what's called the bipolar androgen model, where if you continue to give them more testosterone, the proliferation rate actually drops. And perhaps Abe and Mo and I can talk about that later on. So in my practice, those patients who have prostate cancer, who are testosterone therapy candidates, meet the definition of testosterone deficiency, low T levels, symptoms, and or signs. We routinely get bone densitometry and a hemoglobin A1C in all of our patients who are considered to have testosterone deficiency. And we're using these surrogate markers as confirmation that the patient's testosterone level is low for that patient. This is particularly useful in men who have T levels. The guideline is reasonable, cutoff is 300. We can talk about that later on. But in men who come in who have T levels between 300 and 400 nanograms per deciliter, we utilize these surrogate markers to answer the question, is this low for this patient? Man comes in with a level of 350, he's got some symptoms, we get a bone densitometry, we get a hemoglobin A1C. And if either of those are abnormal, it certainly gives me, makes me feel that these T levels are low for this particular patient. It's a face-to-face discussion with me. They are screened with the testosterone therapy checklist. What's the risk for transference? Are they interested in fertility? Are they on any anticoagulants? Have they a prior history of MACE? And do they have a history of obstructive sleep apnea? And then we don't consent the patients. It's my understanding that Abe and Mo still consent patients, and we can talk about that later. But we do document in the chart that the patient has been made aware of the absence of long-term safety data for testosterone therapy in the prostate cancer patient. This is our checklist. I think all of us in the field use some variation of this. What's the patient preference for therapy? What's the cost of the patient? What's the baseline hematocrit level? Baseline PSA? What's the risk of transference? And by the way, everyone has a risk of transference. We just grade it low, medium, or high. And if you're a man who has a child or a grandchild who's prepubertal, we are very reticent to give you a gel. Fertility interest, remember testosterone turns off suppressive gonadotropins, and in some men, that suppression may be permanent. Baseline LH level to define the patient's candidacy for clomiphene citrate, a prolactin level, what's the anticoagulant medication use, are they a candidate for intramuscular T, and are they using an anticoagulant? What's the risk of VTE? Have they had a prior episode of VTE, veno, thromboembolic events? History of MACE, and any breast symptoms. And I would encourage all of you to utilize this kind of checklist in your practice. We do it routinely. We just decided to kind of formalize it recently, and we published a little expert opinion in the Journal of Sexual Medicine. Our program structure is labs at 2 to 4 weeks after commencement of T therapy, depending on what form of T therapy. If it's a transdermal agent, we check it at 2 weeks. If it's a clomiphene citrate or HCG, or if it's exogenous T, we wait 4 weeks. Intramuscular T, we wait 4 weeks. And included in the T levels are hematocrit, PSA, and an estradiol level. And we always check an estradiol level at baseline before we start men on T. We insist on our labs being done within the Memorial system because we routinely get, we have access to LCMS, liquid chromatography mass spectrometry for total T, and equilibrium dialysis for free T. The labs are done every 6 months. If they live a long distance away from Memorial Lab, we typically recommend that they have their testosterone therapy managed by a physician closer to them. There's an annual follow-up, and all of the patients, while they don't sign a consent, they do sign an expectations letter. And that's a new thing that the institution wants us to do over the last 2 years, which basically tells them what our expectations are of them and what their expectations should be of us. So this is data from Shali Basin. On the x-axis, this is a trial. You can see the weekly intramuscular testosterone dose, and the blue bar is testosterone level, which you see, of course, going up dramatically. And then the red is PSA. And even though the testosterone levels are skyrocketing, there's very little change in the PSA level. Okay? This is our data we published fairly recently. This is looking at testosterone and PSA relationship in men with a diagnosis of prostate cancer. On the x-axis is the pre-prostatectomy PSA level. On the y-axis is the pre-prostatectomy testosterone level. And you can see that solid line in patients with Gleason 8 cancer. There's a disconnect, and that at levels, PSA levels below 4 or 5, this indicates that the patient is at high risk for having low testosterone. So you can look at a patient who has prostate cancer, and you can look at their PSA. And if their PSA level is less than 2, then I can tell you they have an incredibly high chance of having low testosterone. In fact, they have more than a 50% chance of having a T level below 300, and they have a 40% chance of having a T level below 200. So when you see these men, I believe nowadays that when a patient's getting a PSA level checked and it's very low, they should have their testosterone level checked as well. This is just looking at this based on different pathologies. Gleason 6, Gleason 7 with favorable pathology, 6, 7 unfavorable pathology, positive margins, positive seminal vesicles, lymph node positive, and then Gleason 8 or higher with any pathology. And you could look at the different PSA groups. And if you look at PSAs from 0 to 2, you can see a robust relationship between those very low PSA levels and low or very low testosterone levels. Very low is below 200 nanograms per deciliter. So what about patients who have Gleason grade 1, 2, 3? So these were patients with Gleason 6, Gleason 3+4, or Gleason 4+3. These are the new Gleason grading groupings. And these are men with organ-confined disease, pathological post-prostatectomy organ-confined disease. And this is looking at these groups. The testosterone therapy group is on the positive, that's 287 men. And then you've got 8,000 men who are not on testosterone therapy. Median age, as you can see listed, the number of comorbidities, you can see higher comorbidity rate, of course, in men with low T, right? Higher comorbidity rate burden is associated with low testosterone. You can see the preoperative PSA about the same. You can see the baseline T, which is lower in the testosterone therapy group. That's why those men went on and pursued testosterone therapy. And you can see the breakdown by grade groupings, 1, 2, and 3, with approximately the same levels. So a slight difference. And because of the very large numbers, they were statistically significant, but approximately similar across the 3 grade grouping. So this is the Kaplan-Meier estimates of biochemical recurrence. Group 1, testosterone therapy versus no testosterone therapy, no difference. Group 2, no real difference. It looks like there's a difference, but no statistically significance. And group 3, I'll show you the data in a second. Slight difference between the 2 groups. Okay. If you look at multivariable analysis and you look at testosterone therapy, yes or no, the hazard ratio for testosterone therapy in this group for biochemical recurrence is dramatically lower. It's 39% reduction in the risk of having biochemical recurrence, which approaches statistical significance at 0.053. So not alone am I comfortable saying to patients that I believe in Gleason grouping 1 through 3 with organ-confined cancer, that there is no signal that there's any danger. The question can be raised, might testosterone therapy be protective? Baseline T levels, you can see not significant predictor, age at RP not significant, comorbidity status not significant. But I do want you to look at the grade group 2 and 3. If you have group 1, that's Gleason 6, most patients with Gleason 6 are not getting operated on these days. But if you move into 3+4 or 4+3, they are by themselves risk factors for the development. This is not testosterone therapy. This is just the pathology. 3+4 or 4+3 are risk factors for a biochemical recurrence, as is the pre-prostatectomy PSA. This is looking at men T therapy in this group, in the study, and you can see that the graphs are approximately overlapped, which tells me that there is no signal whatsoever that an organ-confined cancer with Gleason groupings 1, 2, 3, that there is no risk for testosterone therapy in causing biochemical recurrence. Now, the median follow-up was just over 3 years, but that's a significant. Most biochemical recurrences in organ-confined cancer, low to intermediate grade cancer, occurs within the first 3 years. So I think this tells us that testosterone therapy is not unreasonable at all in this population. And let's change gears and let's move to men with high-risk disease. And I know Abe's going to talk about metastatic disease, which I'm interested in hearing this data. So these are men with high-risk disease. So Gleason 8 of any kind or Gleason 6, 7 with bad pathology. And there are 3 groups, NT, TD minus, TD positive. And let me explain what they are. NT are men who have high-risk disease with normal testosterone therapy, who are not on testosterone therapy. The TD minus are those men who have low testosterone, high-risk disease, who are not on testosterone therapy. And the TD positive are those men with high-risk disease, low testosterone, who are on testosterone therapy. And you can see the numbers. And, you know, the advantage of being at Memorial is that we've got massive numbers of these patients. You can see the grade groupings there. And of course, it's statistically significant. It's an ANOVA, but you can see very high rates of men with Gleason grade grouping 4 and 5. Grade grouping 4 is 4+4, and grade grouping 5 is 4+5. You can see the lymph node involvement rates, the seminal vesicle involvement rates, and the positive margin rates, which are very high. And that's how you end up in these high-risk disease patient groupings. So this is the biochemical recurrence, and you can see that overall there's a 73% recurrence rate within the first 4 years, 70% in the men with normal T, 78% in the men who had low T who did not get testosterone therapy, and only 51% in the men who had high-grade disease and received testosterone therapy. Okay, now it's 100 or so men. It's not 1,000 men who are in that latter group, but again, there's a clear signal that not alone does it not appear to be dangerous, but there might be some protective effect. Now, I don't know if there are any medical oncologists on the line, probably not, but if there were, they would be having a heart attack at the moment, because that is the group of physicians that is the most difficult to convince that these data are real. The mean time to biochemical recurrence, you can see in the second row. It doesn't reach statistical significance, but it looked to me as if there was a signal that going on T might accelerate if you have recurrence, lower recurrence rates, but might speed up the recurrence because you need T to make PSA, and PSA is the marker. And I think if we can get these patients in earlier and diagnose them with metastatic disease or recurrence earlier, we may be able to offer them better treatment and greater longevity. This is the Kaplan-Meier curve, and the red line is the testosterone therapy patients. High-risk disease, low testosterone, getting testosterone therapy, and you can see a very dramatic difference in the curve shape. So with that, I'm going to stop, Abe, and I do have a case if we have time later, and I'm happy to answer questions when Dr. Morgan Taylor finishes. And I'm going to stop my share now, and Abe, take it away.
Thank you, Dr. Mulhall, for an excellent review. Thank you so much. And I think next we'll move on to Dr. Morgenthaler, who will go into metastatic disease. Thank you so much.
Great. Well, that was an outstanding presentation. For all of you watching, you're getting a treat today. Dr. Kira has been a major figure in the field of testosterone therapy, and especially prostate cancer for about 15 years plus. And Dr. Mulhall is the lead author of the AUA guidelines and has made some tremendous contributions. And some of the data that he just presented was new to me and very impressive. So let me see if I can find my PowerPoint. Uh-oh. Uh-oh. Hope you can hear me. This goes away. This shows up. Share screen again. Uh-oh. I'm going to have to do this with my hands. Open system. Here we go. Yes? Can you see that? Are we good?
I don't see it.
You don't see it, Abe.
I don't see it, Abe.
Oh,
Do you have the share screen?
I did. Yeah, let's go back. Oh my, share screen. Open system preferences. Uh-oh. Oh my.
Do you want to email it?
Do you want to send it to Mo?
Yeah.
Oh, good idea. That's
Just
a
email
great
it to
idea. That's a great idea.
Maybe Mo, we could answer a question or two while I'm sure it'll take a few minutes for that to come through.
Sure. I don't see any Q&A, but I have a question maybe for you, John. It was a fantastic presentation, and you alluded to the fact that there may be some protective effects with testosterone. Let me ask you a question about how you handle patients who get radiation therapy, because it's always challenging, particularly those that get androgen deprivation therapy, and say their testosterone level is 80. And how do you counsel them on what's going to happen to their PSA if you put them on T, and how do you talk to the radiation, the medical oncologist?
So we have a commitment from our radiation oncologist that if the patient is 2 years after radiation, we can have a discussion with the patient about testosterone therapy. Some of the radiation oncologists want the patient's prostate to be rebiopsied, not all of them. We have exceptional circumstances where men have castrate T levels at a year, and they're so miserable and suicidal that we have permission to give them T. Of course, when you're below saturation point, every patient should be told it is very likely we're going to see, if you have a prostate, you're very likely to see a change in your PSA. So we always forewarn them so they don't freak out when they see it. Perhaps we'll have time at the end to talk about the intramuscular testosterone challenge concept, where people have castrate levels of T before we start them on T therapy. We actually challenge them to see what happens to their PSA when they get a normal T level. So,
excellent. I think Abe, you got it.
Okay. Yeah, I got it. Sorry.
Fantastic. Thank you.
My computer went down a couple of weeks ago. I had to do technical stuff, which is not my strength. So I had to get new permission. So that was a phenomenal presentation by Dr. Mulhall. I'm going to talk about testosterone therapy in men with prostate cancer, metastatic prostate cancer. As Dr. Mulhall went through, we've been worried about testosterone and prostate cancer for about 80 years. Dr. Mulhall mentioned the seminal work of Charles Huggins, who really published in 1941 and showed that these men with metastatic prostate cancer had a drop in their acid phosphatase, which was the marker we used before PSA, if they underwent castration or had their testosterone severely lowered. And he also wrote that when he gave testosterone, that their acid phosphatase increased, and he came to this idea that testosterone injections actually cause what he called activation of prostate cancer. And, throughout my training, and I finished in 1988, what I had learned, and this was true for pretty much everyone around the world in the fields of urology or oncology, was that high testosterone caused prostate cancer. Low testosterone was believed to be protective. And that if you gave testosterone to a man with prostate cancer, it was like feeding a hungry tumor or pouring gasoline on a fire. And I certainly used those phrases myself in teaching residents and medical students when I first came out in practice. And it made sense then that testosterone therapy would be contraindicated in men with prostate cancer. And we had terrific fear about doing that, just raising testosterone. I started with testosterone a little bit non-traditionally. I did research before I went to medical school in these lizards. This is Anolis carolinensis on the left. You see the male with the brightly extended flap of skin called the dewlap. And what my work was, project was to put these miniature testosterone pellets in their miniature little brains. And if I put it in the sexual center, which is here right next to the third ventricle, it could restore the entire sexual behavior in these castrated males. And if I didn't place it in the right area, this one's too far away, then they wouldn't get their behavior back, sexual behavior back. And so as I went into practice, I asked myself, could men possibly be like lizards? Because in sexual medicine, we didn't have that much to offer. Viagra wouldn't show up for another decade. And it turned out that men really were like lizards in the sense that treatment with testosterone, if their levels were low, really did restore, not in everybody, but in a high percentage of men, their sex drive, their erectile quality, their sense of intensity with orgasm. And they felt better in other ways. Today, that's not a surprise, but in 1988 and the early 1990s, there was very little testosterone being used, mainly because we were so fearful about the risk of stimulating prostate cancer. And we knew that a lot of men from autopsy studies had hidden prostate cancers that might grow if we raised testosterone. That was what we were taught. But as I started doing it, I got resistance, and I'll never forget the day I was at the American Urologic Association, I think in around 1992, and one of my former teachers came up to me and said, "Abe, I heard you're giving testosterone. You have to stop." And he says, "I tried it in a patient, the PSA went up, and I biopsied, and he got cancer. Your work is dangerous, and you're going to give these guys prostate cancer." And, I was having discussions with these men about the risks of prostate cancer, but they were doing so well that I really, I talked to them. They wanted to keep going, but I always worried that we were making a little bit of a pact with the devil, sex and vigor now in return for prostate cancer and its consequences later. And as John Mahal showed a figure from our paper in 1996 in JAMA. I was so worried about this that I started doing biopsies in the men before I gave them testosterone, even though they had normal PSA, normal digital rectal exam. In other words, they had no real reason to get a biopsy, except they had low levels of testosterone. And I wanted to exclude as well as I could the possibility that they might have a cancer that would grow rapidly, like pouring gasoline on a fire if I raised testosterone. And the surprise to us was that low testosterone was not protective, as we've been taught. And in fact, these guys had a rather substantial risk of prostate cancer, namely 1 out of 4. And that was in a small group of 77 men. But we followed it up in another 345 later. And the rates stay the same. So, the take-home message for you is really that 1 out of 7 men that you treat with testosterone who has a PSA less than 4 likely has prostate cancer that you might detect with a biopsy. Now, a lot of those men were Gleason 6, which today we don't worry quite as much about, but back then we did. But some of them were Gleason 7s with pattern 4 that we cared about. So I no longer believed low testosterone was protective, but I still worried that high testosterone was a problem. And why did I believe it? Well, because how do we treat men with advanced prostate cancers? We lower their testosterone. So if lowering it is good for the treatment of prostate cancer, raising it must be dangerous. And I believed it until my fellow, Hernani Roden from Brazil, and I reviewed the literature on testosterone therapy and its risks, particularly prostate cancer, for the New England Journal of Medicine in 2004. And we were just stunned that even though this concept that testosterone drove prostate cancer was taught around the world, we just could not find any data to support it at all. On the contrary, there were several dozen papers that contradicted it. And John went through the saturation model. I just want to show you something, and that's part of the answer, of course, is that once you have a certain level of testosterone, the prostate cancer can't grow anymore. The androgen receptors that bind testosterone are maximally bound. But this is a great little case that just kind of, I call saturation model in action. So this was a gentleman in his mid-60s who'd been on testosterone for quite a number of years. And his PSA creeped up. And you can see here at the left, he got biopsied at this point, and he had Gleason 6 prostate cancer, which back in 2007, these are month by month by month, 2007, we still worried a lot about Gleason 6 cancer. We just called it prostate cancer. And his doctors refused to continue to give him testosterone. So he went from doctor to doctor, and he ended up at my doorstep, or my office rather. And when I saw him off testosterone, he had exquisitely low testosterone level on his own, 64, which approaches the castrate range. And you can see that because he went into the castrate range, his PSA dropped from 6.4 to about 2.3. And he was on active surveillance. And there wasn't a lot of testosterone therapy in those men at that time. This is one of the first groups, and Dr. Kira and Dr. Lipschultz and I published, and this is one of the patients that was in that initial publication on testosterone therapy and then on active surveillance. And you can see that as I give him testosterone back, month by month, his PSA goes up, and it doubles, in about 3 months. Normally, we would think that's a terrible prognostic sign, but it doesn't go up to infinity. It approaches where it had been before and never exceeds it. This gentleman was on testosterone therapy for about 10 years and never really had any progression of his cancer, and he died of renal failure and fibrosis, what's called myelofibrosis. So over the years, so I call that the saturation model in action. And the concept, if I just go back for a second, if you take somebody into the castrate range from normal, their PSA will drop. If you take them from the castrate range into the normal range here with treatment, their PSA will rise. But once they get to a certain point, it's not going to rise anymore, and you continue to treat them, and it stays wherever it is unless there's something else that will make their prostate cancer progress. So over the years, I started treating men with progressively riskier prostate cancer status, starting with men with high-grade prostatic intraepithelial neoplasia, or PIN, which again today, it's funny talking about some of these things now. We don't really worry too much about this, but back then we were certain that if a man had this on a biopsy, he had hidden prostate cancer, and we would automatically rebiopsy these men within a month or two. And so we published this in 2003, and then other people were doing some work with radical prostatectomy, radiation, brachytherapy, and we started doing a lot of that as well and publishing on it. I mentioned active surveillance. And then near the last few years, I started treating men with biochemical recurrence and metastatic disease. Now, I want you to be very clear that I never did any of this cavalierly. I've been afraid since 1988 that when I gave testosterone to men, it would cause prostate cancer. And if they had prostate cancer, it would be like pouring gasoline on a fire. I've been waiting for that inevitable patient who would have some dramatic, terrible adverse event or death. And amazingly, it has never happened. So I want to show you a couple of cases, and then I should have some data slides in here. This was the first guy who came to see me who with metastatic disease who wanted testosterone. He was a 94-year-old scientist. His brain was totally sharp. He had about 100 patents to his name. He came with his daughter, who was a nurse practitioner. He had terrible disease. He had Gleason 9 cancer. He had diffuse bony metastases. He had bilateral nephrostomy tubes from ureteral obstruction. His PSA was the highest I'd ever seen at that point, more than 500. And he had tried androgen deprivation, which of course is the standard treatment for men with metastatic disease, but he hated it. And he stopped at 6 months. He was too weak to do anything. And he comes and he asked me for testosterone therapy. He said, I've read your work. I want you to give me testosterone. And I said, what do you want it for? And he said, well, I used to exercise every day. It made me feel good. And I've got colleagues all around the world. I used to correspond with them. I'm just too tired. That's what gave me pleasure in life, and I just can't do it anymore. And I said, you could die tomorrow in a week. And he said, Doctor, I've never lived my life in fear, and I don't intend to now. I'm 94 years old. I've got metastatic cancer, and I know I'm going to die sometime. But while I'm alive, I want to live as well as I can. So this may be out of sync, but it's worthwhile. This is actually from Dr. Kira's laboratory, and looking at LNCAP cells, which are this androgen sensitive prostate cancer cell lines that have been used for a couple of generations now in studies. And the three different groupings here is just how many cells they put on each plate. And as you go from left to right, you start off with 0 doses of testosterone, 0 concentration, then it increases. And you can see that at the beginning, there's a rise in the cell growth of these prostate cancer cells. And then at higher doses of testosterone, there is growth inhibition. And not a little inhibition, a lot of inhibition. This black line here on the left, or here if you like, or here, is with no testosterone. And here they are with high dose testosterone, and you can see how little growth there is. Astonishing. And Dr. Kira also did a study in vivo with rats or mice, where you can transfer the prostate cancer tumors underneath the skin of the rats. And he looked at high testosterone doses, low testosterone, and no testosterone. Again, showed that high testosterone had some beneficial effect compared to the others. The idea of high testosterone in men with metastatic cancer, there have been a couple of case studies that have been published for going back quite some time. But the group that's run by Sam Denmead at Johns Hopkins really has changed the whole way of thinking about things with their studies of what they call BAT, bipolar androgen therapy, in men with metastatic disease. And what they do is they have 4-week cycles where basically testosterone goes very high and then very low. And that's why it's called bipolar. And so the patients are on an LHRH agonist, so they have making essentially no testosterone of their own. And they get a single injection of high dose testosterone every 4 weeks. And at the end of 4, so their levels go up and then they go really down. And then at 4 weeks, they get another high dose injection. And what they showed is that the PSA declined in about half of these men. And in men who had nodal disease, and you can see some of the comparisons here before and after, they showed shrinkage of tumors. Amazing. See, these are men with castrate-resistant prostate cancer. These men have a terrible prognosis. Not long ago, they published something they called the Transformer trial, where they had about 100 men in 2 arms, one getting BAT and the other getting a standard sort of super ADT, which is enzalutamide, and showed equivalent results. And so these guys basically showed that testosterone as part of a treatment protocol, it's not continuous testosterone, but it's a cycling, actually may have important beneficial effects, at least as good as the standard therapy with enzalutamide. This is my patient, GS, and I started treating him with high dose testosterone as some of these studies came out. This is a picture at 7 months. His daughter sent me this. He's sitting in the waiting room of his dentist, and he's 95. I think he looks pretty darn good. By 1 month, or rather by 6 weeks, he told me that his brain was clearer. He was working on his next patent. He was exercising. His appetite improved, and he'd been very thin and had added some weight, which was well needed for him. You know, in my day, as in our training, we were told and taught that testosterone in these men, especially if they had bone metastases, would cause terrible bone pain. As a matter of fact, one of the most common ways that men presented to the doctor with a new diagnosis of prostate cancer when I was a resident, mid-80s, was with bone pain. We didn't have PSA back then. It was just being introduced. And so they'd come in with bone pain. They'd get a radiograph wherever the pain was, and it'd show blastic tumors, which usually is prostate cancer. This gentleman was so happy with what had happened, which ran counter to what all his doctors had told him would happen with testosterone, that he sent me his picture, said, use my name, show my picture, tell my story. Another patient of mine who I had put on with metastatic disease with a nephrostomy tube, also for obstruction, had been on pure testosterone for a while. And he started with a PSA, if I remember right, around 30. And it rose over time to 50 to 70 to 90. And he was feeling good. And his studies showed no progression by imaging. But when his PSA went above 100, he got nervous and he stopped. He had never tried ADT. He said he didn't think it sounded natural to him. And he liked his testosterone. So he went off my testosterone treatment, went on ADT with his oncologist, and eventually came back because he was unhappy. And he'd seen the work by the Denmead group with BAT, and he said to me, could we do something like that where you give me testosterone, but instead of once every 4 weeks, you give me a longer period of time on testosterone? And so I came up with what I can call the modified bipolar androgen therapy, or MBAT. And they get 8 weeks of high dose testosterone, which is 400 milligrams intramuscularly every 2 weeks. And then it's followed by 4 weeks of an anti-androgen. My favorite was enzalutamide because it really stops things cold in terms of androgen activity. And then at the end of the 4 weeks, they go back on 8 weeks of testosterone again. So even when they're feeling lousy, they kind of know the cavalry is coming and it's not so bad for them. This is his data, again, over 2 years. So this starts down here, April 2017. Here's April 2019. PSA is in blue, and in orange or rust or whatever color you see on your screen is testosterone. And you can see the seesaw pattern because as the testosterone goes up, his PSA goes up. And as the testosterone comes down, his PSA goes down. So if you look at the naders, the low levels of the PSA, there is a rise over time. But in general, we had pretty good PSA control. This gentleman is still alive. He stopped the MBAT because he found that his pelvic pain got worse as he was getting treated with this. So I've used up, I think, probably too much of my time. So let me just go quickly through this. So we published this past year in androgens, testosterone therapy in men with biochemical recurrence and metastatic prostate cancer. And our numbers were, we had 22 men, 7 with biochemical recurrence, 13 with metastases, and 2 were considered at high risk, and they were placed on androgen deprivation immediately following CyberKnife. Median age was 70, median duration of testosterone therapy was 1 year. And all the men stayed on to the treatment because they got benefits from it. This is the change in PSA that you see with biochemical recurrence. So over time, biochemical recurrence, PSA will rise anyway, given enough time. And with metastatic disease, it definitely goes up as well. Our mortality data, we had 3 deaths for 13.6%, but only 1 patient died of prostate cancer, and that was the 95-year-old gentleman that I showed you. 1 died of myelofibrosis after 7 years, and 1 of them died after complications from a heart attack. In terms of morbidity, 3 men had increased bone pain developing at 7 to 41 months after beginning it. I talked about this man. 1 man needed bone marrow transplant, replacement, urinary retention, 1 DVT. But the things that I'd been taught were dangerous, like they're going to get a pulmonary embolus, spinal cord compression, pathologic fractures. We didn't see any of these. And the amazing thing for me is that in the metastatic group, 7 out of 10 showed no progression within 1 year of treatment. And so I would just say, this talk is different today than it was even 5 years ago. And I think it's because of what the great physicist Max Planck said. It's a new scientific truth does not triumph by convincing its opponents and making them see the light, but rather because its opponents eventually die and a new generation grows up that is familiar with it. I think the current generation, including probably most of you, are much less afraid of testosterone therapy with prostate cancer than any of the speakers today were. And should you offer testosterone therapy to men with metastatic disease, the cons are obvious. Progression will occur. People believe that it's going to make the prostate cancer get worse. But I would just point out that progression is going to occur whether they get testosterone or not. We don't have a cure for metastatic prostate cancer. The biggest risk, I would say, is medical legal, because you still have a lot of colleagues that will say that it was the testosterone made the cancer progress. But the reasons you should consider it or might want to is that men can live for many years with metastatic disease. It's not unusual to live 10 years, for example. We pick it up earlier and earlier now. And some men are willing to risk a better life for a possible shorter duration of life. We have no data, none at all, that testosterone therapy shortens life, even in men with metastatic disease. And we have evidence that high dose testosterone can actually inhibit prostate growth. I've shown you some of the published evidence about this. So if you decide to do it, make sure that you speak very clearly with your patients. You tell them we don't have a lot of data, that they could die from it, they could have adverse effects, but there's some reassuring evidence. And I would just end with, I would just say, where is it written that all men with advanced prostate cancer must be condemned to live out the rest of their days without testosterone, weak, tired, and sexless? Thank you very much.
Thank you so much, Abe. And I just want to thank Abe and John both for some fantastic lectures, extremely thought-provoking. You know, just listening to both of you, I'm just in awe what, you know, for the past 15 years, our understanding has completely changed. What we used to know about prostate cancer and today. So really very thought-provoking. We have some time for some questions. I'm just going to read them out for you. The first one is from our own Dr. Amy Perlman. And her question is, do you ever try HCG only therapy in post-ADT patients to boost endogenous production, suggesting maybe it's different boosting endogenous versus giving exogenous in this population? Either one of you, please.
Maybe I could start. So we tried to get a trial off the ground in our post-radiation patients looking at clomiphene. I think Amy's point is that we probably don't want to be putting somebody on exogenous T too early after ADT cessation, because it takes a while for recovery and you don't want to suppress that. I don't know that we have any evidence that it does suppress it, but so we tried to get a trial off the ground looking at clomiphene and we couldn't do that. But we do use clomiphene in those patients, Amy, rather than HCG if their LH level is on the low side.
I would just say quickly that the reason to avoid testosterone is mainly because people think testosterone is contraindicated in men with prostate cancer. So early on, before I had all my mojo, early in my career, I treated a couple of men with Clomid, as John just mentioned. But the effect is the same, right? Like we're raising testosterone. But Clomid, I made this argument in my head. We weren't using we weren't using much HCG back then. Like HCG was around, but it was rarely used. Now we use a ton of it. And you know, what I said to myself is, well, I'm just raising his own endogenous testosterone. I'm not really giving him testosterone. But really, all of us understand we were doing essentially the same thing.
Yeah. We have quite a bit of questions coming in, so I want to try to get through some of them. How long post-therapy would you consider adding testosterone, or do you wait to a certain PSA level? I'm assuming they're probably referring to either radiation or radical prostatectomy. Is there a time frame that you need to wait in order to say that it's safe?
We check a PSA after prostatectomy at 8 weeks, at 12 weeks. If the PSA is undetectable, then we'll have a conversation about testosterone therapy. It used to be just in Gleason 6s, and then it was just Gleason 6 and 7s, and now it's everyone, including like men with Gleason 10. And then we have a conversation about the pros, cons, and risks and benefits. So 12 weeks out, we'll have a look at the PSA and see how it is. If the PSA is undetectable and you believe the PSA, because if their T level is so low below saturation point that you're not sure the PSA is real, that's when we do the intramuscular challenge. But we'll have the conversation very early. After radiation, we will use clomiphene in patients early on because we don't want to suppress the natural recovery. If you get 3 testosterone levels like every 3 months that are the same, you can probably presume that they're not going to get much benefit by waiting any longer.
You know, I would just add quickly that I think biologically it makes no difference when you start it. because I don't think testosterone is bad. As a matter of fact, John's data might suggest, and Tom Allering has a great paper too in Radical Prostatectomy Group, that the men who got testosterone had a lower risk of biochemical recurrence than the men who never got it. So maybe it's even beneficial, which is part of the title of this program. But I think if we're just playing neutral here, I don't think it makes a difference. But there is an important reason to do what John just said, which is to wait for that first PSA. And the reason is, let's call it medico-social. So if somebody hasn't dropped their PSA all the way, they probably have biochemical recurrence. I think the conversation in those men is very different than if they have an undetectable PSA. So I think it's worth waiting for that first PSA, and then your conversation will be guided by whether they appear to have a hopeful cure or recurrence.
Excellent. One question is, how do you explain the physiological mechanism for why prostate cancer patients have low T? Like, why is that? Any thoughts on the mechanism? Is it the low T? And I've always, when I give my lectures, I always say, is it really the low T causing the prostate cancer, or is it the prostate cancer causing the low T? Because there's some data that suggests that when you do a radical prostatectomy, the T levels will rise. You do a suprapubic prostatectomy, you don't see the rise. But I'm interested in getting your opinions.
Well, I've got a brilliant friend who's a cancer biochemist. And I love the analogy he gave. It's a little simplistic, but I'll share it. He says it's a little bit like a bear, the prostate cancer. And if fish and berries are plentiful, he doesn't have to go anywhere. He can just stay close to home and he's fine. But if there's not enough food for him, or if something changes in him that's not his diet anymore, then he has to go in a further radius from his set point and do other things. And essentially, the low testosterone state, I think, is an abnormal state for the prostate. It makes the cells want to shrink, and they have to do something else to stay alive. And using the analogy, some of them may actually transform and do what cancer cells do. It works for me. That's how I think of it. I don't know if it really works in the big picture. Hungry bear.
I genuinely believe that a low T level is associated. The data would suggest this, and I think it's real. Higher risk for higher stage, higher grade cancer. And I think that's biological. And I think that's the direction that the relationship has.
Well, unfortunately, we are out of time, but I just want to thank both of you, John, Abe, for some fantastic lectures, thought-provoking, cutting edge. Really can't thank you both for your time. I want to thank Endo Pharmaceuticals again for their support. On behalf of the SMSNA, thank you all for joining, and have a good evening. Thank you.